All right, good morning, everybody. Glad you all found your way here on this icy, snowy morning. Well, not so much snowy, I was hoping for that, but icy still anyway. Can you hear me back there? I think you can hear me. I want to welcome you all, and before we introduce our speaker this morning, today is the second annual Richie Wernick lecture, so I'm going to invite Mark Rosenberg, our former program director, up to the podium to say a few words about Richie.
It's an honor and a pleasure to be able to stand here. Rich and I got to work together for 37 years. Our offices were next to each other for 37 years. And Jesse asked me to say a couple of words that captured Rich. And I actually thought about it as three places that capture him. I think about him in his office with a resident teaching, hearing him have the structure of every rheumatologic disease and giving that to the residents. But secondarily, being able to talk about the uncertainties that went on in medicine, that it wasn't just the appeal of the concrete, it was actually the wonder of the uncertain that really appealed to Rich. And rheumatology wasn't enough in that room because you heard him talking about evidence-based medicine constantly. There's no resident that's graduated from this program when they hear the word sensitivity or specificity, they don't think about Rich Wernick. And it wasn't just the medicine. You heard the way he connected with residents. The laughter, the pushing of residents, not physically, but except maybe in the old days. But also caring about them as individuals. Hearing Rich share his dogs, his baseball team, hearing him ask the residents about what they were doing in their lives, how they were doing in the residency. That connection is something that shaped all of our residents that time at Bench. Second place I think of him is in Morning Report. Leading Morning Report, he was a master. His ability as a rheumatologist to bring literature from any specialty, from any piece of medicine, was remarkable. To be able to bring it to bear appropriately, but also to ask the critical question, one that really helped residents explore a case, to realize that it wasn't as simple as going from A to B, but you had to really understand what was going on underneath. His ability to make people feel that literature was relevant, but yet to bring a certain skepticism nigh onto cynicism about truth, being able to find truth in medicine. The literature guided us, but it didn't totally shape what we did. And then the third place I think of him is right in this room. Rich shaped grand rounds of this institution. He elevated it both with the quality of the speakers that he was able to recruit, with the preparation that he did with them to orient their talk to the audience. But also, I picture Rich standing here as we started to ask questions. And the questions that he would ask, the depth of knowledge that would represent, and the sense of preparation that he thought about what was a question that was important, not just to him, but to all of us in the audience, was a gift that he brought us. And so I'm really excited to be able to bring his presence into the room for all of us so that we can listen to today's talk with a curiosity, with a wonderment, with a certain degree of skepticism. And I think that as we listen, and then as we get ready to ask our questions after the talk, I want to imagine Rich sort of here with us, being part of it, and we'll be mouthing the questions that he would have asked. So thank you for allowing me to speak briefly.
Thank you, Mark. believe me, I think about Richie every time I stand up here, and him standing there, and yeah, we miss him. Well, our speaker today, Dr. Prasad, caught my eye with an editorial piece that he wrote in 2013 to the Washington Post. It was after President Bush had gone in for a stent. The title of his opinion piece was President Bush's Unnecessary Heart Surgery. And in it, Dr. Prasad argued that if Mr. Bush, who at the time was able to ride 30 miles on a bike without any chest symptoms, had, quote, visited a general internist practicing sound evidence-based care, he would not have had so-called routine stress test, which found an incidental blockage for which trials have shown does not improve symptoms or survival. However, does increase the use of procedures such as coronary stenting. Is this kind of incisive, critical, and even witty critique of prevailing medical practice, firmly informed by evidence-based medicine, that made me think Dr. Prasad is the ideal speaker to honor Dr. Wernick's legacy. He has a book out about medical reversals, and he has a new forthcoming book out about cancer, the tagline for which is how hype, money, and bias can mislead the public into thinking that many worthless or unproven treatments are effective. So I think you get where I'm coming at with him fitting Dr. Wernick's legacy. Dr. Prasad studied at the University of Chicago for his medical school and attained an MPH at Johns Hopkins. He did his fellowship and residency at the National Cancer Institute, fellowship also at the National Cancer Institute. He joined OHSU in 2015, where he's Associate Professor of Medicine. He also has an appointment in the Department of Public Health and Preventive Medicine. He's a senior scholar in the Center of Healthcare Ethics, Assistant Program Director for the Hem/Onc Fellowship at OHSU. He's been an ad hoc reviewer for dozens of journals, including Annals of Internal Medicine, JAMA, BMJ. He has well over 200 articles to his credit, and we are so pleased to welcome him here as our speaker today. Dr. Prasad.
Thank you so much. Thanks so much for that. And this microphone is working? You can hear me? It's on in my pocket. Yeah. Can you hear me in the back? No. Let me adjust it. Hello? Maybe it's just the location of the microphone. How about now? That's better. Okay, so it's working. Thank you so much for that very kind introduction. I don't think too often of that op-ed piece that was written many years ago. I was a government employee at the time. I was a fellow at the NIH, and so I got in a whole heap of trouble for having written that article. And in retrospect, I'd have done a few things differently, but I do think that the central idea was probably right, which is you get somebody who has a really almost unlimited exertional tolerance. He was biking like 50, 100 miles the weekend before and do a routine stress test, find a blockage. I'm not so sure you benefited them by finding it. But thank you so much for having me. I should mention one thing, that I'm going to be moving from OHSU to the University of California, San Francisco in April. So just to give you an update. But this talk is called How to Keep Up with New Information in Medicine. It's actually something I get asked about a lot. And in talking about it, I think we'll also kind of explore some critical thinking in how to read articles and how to read them with a healthy skepticism, which I think would speak very nicely to the namesake of this lecture. In terms of disclosure, I'm the author of these books, but they're published by Johns Hopkins University Press, and they're academic books, so that's why I'm a very rich man. One day there won't be laughter when I say that. That will be the day. And then I make a podcast on the iTunes store called Plenary Session. It's free and available to anyone. And if you're interested in some of what I talk about today, you should check it out. We go through a lot of clinical trials in some detail. And my research is funded by a nonprofit foundation, the Laura and John Arnold Foundation, that's based in Houston, Texas. And I'm on Twitter, that handle. So, this all started with a case that made me start thinking about how do we keep up with new information. And it was the 60-year-old sister of a 65-year-old patient of mine who has multiple myeloma. So I'm treating the sister, and the sister's in the room. The 60-year-old sister is obviously concerned of multiple myeloma, maybe that she might someday get it. And she asked me a tough question. She says, "Doctor, should I increase the amount of exercise I do to protect me against getting multiple myeloma? After all, my sister is a patient of yours, has multiple myeloma. And I said, wow, this is not an easy question. You're asking me, should you increase exercise to reduce the incidence of myeloma? And then she said, well, didn't you read the new study? I said, oh boy, oh boy. Oh, well, I gotta answer that just right. So, after this visit, I did look up what is this new study she's talking about, and it got a little bit of press coverage. But here's the study. It appeared in the JCO earlier that week. It was called Amount and Intensity of Leisure Time Physical Activity and Lower Cancer Risk. So this is about what you do in your leisure time, your amount of physical activity, and your incident rate of developing cancer. And it goes cancer by cancer. And so I looked through, and buried in this paper, one of the cancers for which they find a signal is in fact multiple myeloma. And they say that your hazard ratio of developing multiple myeloma depends on how much you exert yourself a week in metabolic equivalents, in METs. And if you go up to 15, there's a benefit, and then maybe there's some sort of diminishing, there's a sweet spot of how much you should exert yourself to lower your risk of myeloma. And of course, they looked at every single cancer under the sun. They looked at maybe 40 cancers. And then I reminded myself that I don't know what a MET is. So I was like, what is a, I see it, but I don't really know what it means. So I was like, how many METs do I do a week? So I looked up, obviously, in Wikipedia, which is the go-to source, and I find that, it's divided into light intensity, moderate intensity, and vigorous intensity activities, and that say tennis doubles. If I play doubles tennis, that's 5. So if I play doubles tennis 3 times a week, I'm at 15 a week, that's the sweet spot. If I do yoga, that's 3.3. But if I do it with vigorous transition jumps, I could bump it up to 7.4. I'm a bicycle commuter. After all, I live in Portland. And so, that would be 6. So I thought to myself, well, I'm a bicycle commuter. I immediately think about myself now. And then I said, I'm a bicycle commuter. I'm doing, getting at least 6 a few times a week. Maybe I'm out here on the curve. So my risk of cancer is good. I also noticed that they have included sexual activity, but they've I don't know why they include it for only a certain age group. I find that very ageist and demeaning. So I didn't understand that. But I dug in more into this paper because, of course, I was just looking at the paper, but there was a supplementary appendix, and I looked in the supplement, and here's what I found. That association, that myeloma and incident cancer, it depends on the type of exercise you do. So if you do moderate exercise, there's this protective signal. But if you did vigorous exercise, like me bike commuting, there's nothing at all. It's totally null. See that? So then I felt, oh boy, I was going too fast on that bicycle to keep myeloma at bay. And then I thought to myself, what theory of physiology does one have to have for this to make any sense at all? That you exercise in a mild way and your myeloma is prevented with a hazard ratio of 0.8. But then you go a little too fast and myeloma comes right back. I mean, that's how I felt. It's like, this makes no sense. And I actually think that if I were to actually say, like, what are the real criticisms of this paper, I would say, one, it's a little bit of an implausible finding. It's implausible that a certain amount of exercise, moderate exercise, is protective, but then the moment it gets to vigorous, it's suddenly totally null. I mean, it's a bit implausible from anything we know about biology. This next thing is the potential for multiple hypothesis testing. How many cancers are there? And how many different ways can you slice and dice how much someone exerts oneself per week? And how many different people are interested in studying exercise in retrospective data sets? It's quite a lot. And so when you think about all the people who could study the question, how many times the study has been questioned, all the different analytical definitions, all the different cancers you could be probing relationships, in this paper, they don't find a relationship with every cancer, just maybe 6 or 7 out of all the cancers they looked at. There's a potential that some of the results that you see as significant are just merely luck of the draw. You've looked so many things. Next, there's an issue of confounding, which I think that if you are ill or have some underlying autoimmune condition, underlying illness, chronic kidney disease, you might be both less likely to exercise and more likely to develop incident cancer. So there might be some sort of root confounder that they're not adjusting for. And finally, I looked in this paper to say, how do they even know how much MET somebody did years before they developed cancer? And of course, it's all based on self-reports. And I know that self-reporting, particularly dietary intake and food, is not always the most reliable finding. So I think these are kind of the core problems with this paper. But what do I tell the patient who's asking me, did you read the paper, doctor? Did you read it? Well, I say what all good doctors learn to say after years of practice, which is you redirect, just like a politician. I say, well, are you asking me, do I believe if staying active is part of a healthy life? Well, then I absolutely believe that, if that's what you're asking me. If you're asking me, would I stay active specifically to avoid myeloma, I would put it to you this way. I would say I would stay active as part of a broader pattern of as part of a broader pursuit of general and cardiovascular health. That's how I answer the question, expertly dodging the real question. And then she followed up, but have you read the paper? And I had to say, no, I hadn't read the paper. No, of course not. I've not read this paper. I can't read all the papers out there. And no one can read all the papers out there. And that's the problem. So what are the key objectives of this talk? Admitting that we cannot read all the papers. What are the best techniques to keep up with the literature? So I will give you my non-evidence-based techniques, how I keep up with the literature. What are some examples of studies that are commonly, classically misinterpreted? And how might we be better about thinking about those studies? And then how can you be a better reader of medical information? I think those are what I hope to convey to you in this talk. There are 50 million scientific articles indexed in Medline to date. I mean, that's a mountain of articles, science and medical articles, and they're coming at a pace that we cannot keep up with. This came out of The Economist a few years ago. This is the pace of articles being published in science and medicine, and this is 2013, already a few years old. We're past 2.5 million new articles per annum. In terms of clinical trials, we're at 50,000 plus clinical trials per annum. No doctor can read all of the clinical trials, prospective human clinical trials that come out a year, maybe not even in their own field. I can't even read all the prospective trials in oncology. Even if I spent all day reading, I couldn't get through them all. So it is impossible to really keep up with the literature in a way that one might have done, decades ago. But when we simultaneously have so many articles, but every time you read the headlines about these articles, you read words that don't sound very reassuring, that there's replication, duplication, and waste in 250,000 systematic reviews and meta-analyses. That doesn't sound so good. I read this, the mass production of redundant, misleading, and conflicted systematic reviews and meta-analysis. That doesn't sound reassuring, and that there are challenges in irreproducible research, that a lot of our research is not reproducible. We're duplicating efforts. Some things are misleading, and the authors may be conflicted and have biases that drive outcomes one way or the other. And so I think for all these reasons, even though we live at a time where there are more articles than ever, I wonder how many are conveying useful information that should affect what we do. So in case you want to tune out this lecture and perhaps just watch an iPad video, you can read this article instead, 21st Century Physician, Triaging the Tsunami of Medical Information. I wrote this for Medscape a couple years ago, and it kind of gets at the gist of this talk, which is how do we, as 21st century physicians, or any healthcare provider really, how do we triage this tsunami of information that we're getting each year? And I use the word triage because I think that's what we're really going to need to do. We have to use the triage skill that we use as providers for patients in emergency settings or in settings where there are resource constraints and apply that to the body of literature that's hitting us. We cannot look at every single paper. We have to triage what's important from what isn't. Okay, so this is one of my first principles of how you triage. I think if you want to read medical articles, you will never read medical articles if you say, I'm going to do it someday. You're never going to do it. I'm going to print articles, and I'll read them when I go on vacation or when I have a flight or when I do, and then I get on a flight and I fall asleep and I go on vacation. I don't want to read an article. I'm on vacation. You're never going to do it if you plan on doing it someday. The only way you're going to do it is if you build it into your life, if it becomes a habit. And if you're building a habit in your life, you don't have much time. You can't read 10 articles a week. You'd be lucky to read 1 article a week, maybe 2. 1 or 2 maximum is what you can read. I mean, realistically, with the time that we spend with charting and patient care. And I think the only way to do it a little bit every week is to build it into your routine and your habits. So here's what I suggest. Timing is everything. You need to pick a few journals. I'm going to show you the journals that I pick, but whatever your field or interest is, pick 1 or 2 journals and learn when they put out the articles. So for instance, JAMA Internal Medicine, that's 12:30 p.m. Central Standard Time every Monday. That's when they drop the new articles on New Online. JAMA, that's Tuesday, 12:30 p.m. Central Time. Wednesday, of course, New England Journal of Medicine, 2 p.m. Pacific, 5 p.m. Eastern Standard Time. That's when the new articles drop. JAMA Oncology, of course, comes on Thursdays, and the JCO comes out on Mondays. They kind of trickle them out. So these are just the journals that I happen to look at. But I think it's super important to know when it comes out. Because I know if it's Wednesday, and I'm waiting at the elevator, and it's 2:15 in the afternoon, and the elevator is slow, which it always is, I'm gonna pull out my phone, and I'm gonna go to the New England Journal website, and I'm just gonna look through the titles of the articles. I'm just gonna look through the titles because I know that's when a bunch of other people are looking through the titles of the articles. And I'm gonna see what strikes my fancy, because the reason that timing is important is just like the timing of TV shows. People are gonna be talking about it at the water cooler. They're gonna be talking about it the day after it comes out. But of course, we don't talk around water coolers anymore. They're gonna be talking about it on Twitter. They're gonna be online talking about it, actually. If articles come out in the New England Journal of Medicine at 5 p.m., you can rest assured 7 p.m., 8 p.m., Thursday, that's when people are gonna be talking about those articles. And you don't have to have read the article, but I think it's worth it to you to at least know what articles came out the day before and to follow a little bit of the conversation. So although I cannot endorse this website for everybody, and I'm not saying you should go out and tweet your opinions, I think it's super useful for practicing doctors to have an account where you keep an eye on a few people. So for instance, if you're interested in cardiology, you can follow Eric Topol, Venk Murthy, John Mandrola. There are a few cardiologists who are really good readers of cardiology literature. And when the articles come out at 5 p.m. on the New England Journal, they're going to be chiming in with their 2 cents into the evening and into the early morning. And so already you can kind of get some critical feedback without even reading the article, what some experts in the field may think. And you build up your own network of, I guess I follow 989 people, whoever you think is a good, saying something very critical or interesting about articles. But so I think it's important to look at the articles a little bit when they come out, because the conversation's going to be happening right afterwards. And you at least want to kind of listen in, at least in the beginning. When you triage articles, these are sort of some general principles I have. They're not hard and fast. They're sort of heuristics. Which are the articles that are going to stay on my screen longer? I think most of them, they're going to fail at the title stage. Some of them I'm going to skim the abstract, and maybe 1 or 2 a week I'm actually going to read. And here's how I decide, what are the 1 or 2 going to be? Does it pertain to my practice or my interest versus not? Most articles, frankly, even in the top journals, they don't pertain to my interest. Is it randomized or an observational study? I think observational studies, especially for causal questions, are often lead to misleading results, which we'll talk about later. Randomized trials aren't perfect, but they're more likely to stay on my screen. Was the trial a multi-center study, or was it single-center study? Multi-center trials are probably, especially for certain types of things, quality and safety metrics, more likely to lead to reliable conclusions. I'll give you a couple examples. When it comes to blood sugar control in the ICUs, it was a single-center trial from the Netherlands that said ultra-strict, tight monitoring improved cardiovascular outcomes and improved death. That failed to be replicated in the multi-center nice sugar study. Early goal-directed therapy, the Manny Rivers study, came out of a single-center Henry Ford Hospital, failed to be replicated in multi-center studies. When you talk about complex ICU procedural interventions, the real question isn't, can one hospital do this and improve outcomes? The question is it scalable? Can we all do it and improve outcomes? And those you really need multi-center clinical studies. So I think multi-center, I'm more likely to look at it longer. The sample size, if it's a 400-person randomized trial versus a 40-person randomized trial, that makes a difference to me in point estimates in reliability. So it's more likely to stay on my screen. And what's the endpoint of the study? Is it how long I live or how I feel, AKA a clinical endpoint that we care about? Or is it my LDL level, the size of my tumor on a CAT scan, the amount of a protein in my bloodstream, a surrogate endpoint, an endpoint that doesn't really matter to me in and of itself? And so I want to say, not as a hard and fast rule, but if it pertains to my practice, if it's randomized, if it's multi-center in a bigger study with a clinical endpoint, that's more likely to be the study I read that week. When you get the article from the New England Journal of Medicine, you will die if you try to read the articles cover to cover. I mean, I just think that they can be boring and you'll fall asleep in the introduction. And, you know, we've all struggled to read an article when we're tired or busy or overwhelmed. And I think that that's not how I would approach them with such a limited amount of time and attention that you have for this. I think you have to have questions in your mind and set out to answer those questions in the article. So you're going in and you're just shooting in for answers. Just 5 questions maybe. 1, what was the intervention? I want to be able to say in my own language, like, what did they even do here? And I want to say something like, okay, this is one of the examples I'm going to give you in a little bit. They took patients who had germline BRCA mutations and happened to have pancreas cancer. And then they gave these patients a standard of care chemotherapy for 4 months. I probably would have done 6 months, but they gave them 4 months, whatever. And then they found that some people, the cancer hadn't grown, and they randomly assigned them to this new fancy genetic pill. I'm not sure how it works, but it's new and fancy, or a sugar pill. That's what they did in this study. I want to be able to say that, like, off the top of my head. So I want to just, like, read in the paper to be able to articulate, what did they do? Simple question. 2, did the control arm of the study get what I would have done? That's my next question. What did they give the control arm? Sugar pill. Okay, then I think, all right, so they're really saying that in this setting, you don't have to give anything. Is that what I really would have done? And I ask myself, and I say, well, you know what, in this case of pancreas cancer, that's probably not exactly what I would have done. I probably would have given a couple more cycles of chemotherapy, but after 6 cycles, maybe then I would have dropped one of the medicines and given one of the drugs by itself, or, you know, it may be whatever situation you're in. You have to ask yourself, would you have done the control arm? I think a good example is the SPRINT trial. The SPRINT trial is a trial of blood pressure targets for elderly patients, and it has the first to show that ultra-strict targets improve cardiovascular outcomes and stroke over more permissive ones. But if you look at the control arm and you read the paper, it says, if my patient had a systolic blood pressure less than 130 on one occasion that is without symptoms, I would have to dose reduce the medication on the control arm. But would you have really dose reduced in clinical practice? And I think the answer is you wouldn't if they were asymptomatic. And so it kind of artificially creates a difference in blood pressure by taking people who are exquisitely sensitive to antihypertensives, dosing them down, which may actually kind of penalize the control arm rather than prove the intervention arm is beneficial. But I think the question here is it really reflect what you're doing? So many of these trials, you're testing a cancer drug against a drug we haven't used in 15 years in this country. I mean, that's just a simple fact. What was the effect size? Was it small or was it big? Was it something that's clinically meaningful or was it merely statistically significant? I think you just have to look and shoot in and try to get that answer. Of course, here I ask again, clinical or surrogate endpoint. Does it matter to people or is it something that's a stand-in? I always like to ask, what happened after the trial ended? You know, in cancer drugs, we do a trial for 4 weeks, but survival is often short. Once the patients came off the study, were they getting the standard of care in the United States? Were they getting all the subsequent drugs we would do? Or was the study run in Eastern Europe, where there may not be availability of any drugs after the study? And in fact, it was a study of some drugs at some point in time, and then really just supportive care, which is not reflective of what we do in this country. And then I ask, any games with patient selection? Are there ways in which they're picking and choosing patients that kind of doesn't make sense? So let me give you some examples to flesh these out. But I guess the point here is, I'm not reading the paper. I'm just shooting in and answering these questions as quickly as I can. I know to look in the methods for some and the results for some, but I'm not reading out the whole thing cover to cover. Not yet, at least. Entresto, blockbuster medication, sacubitril valsartan, a game changer for heart failure, and a very powerful paper. You like the trial? All right, so this paper came out in 2014, the Paradigm HF paper. And it came out September 11th, 2014. I think it actually came out September 11th at 5 p.m. Eastern Standard Time. It's a Wednesday. I bet it's a Wednesday, because that's when they like to put the articles out. So I remember reading this article at the time, because not only was this in the New England Journal of Medicine, it was also on every network, NBC, CNN. They all had like news stories, because it was the first drug in like decades that improved overall mortality and heart failure. We had not had such a drug. And this is a big paper. It's a paradigm-changing paper. And in fact, you know, I saw this paper. The first thing I zoomed in was, okay, let me just check one thing. Did it improve death from heart failure or composite cardiovascular endpoint, or did it actually improve all-cause mortality? And lo and behold, it improved all-cause mortality. hazard ratio 0.84, lots of zeros and a p-value, and a big improvement in all-cause mortality. Then I asked myself the other questions. What was the intervention? Well, it was LCZ696, which is valsartan, an ARB, which I know about, and sacubitril, drug that I don't know about, but some new drug. And what was it tested against? Enalapril. Okay, enalapril, all right. And what dose of enalapril? 10 milligrams BID. Then I said, okay. Then I asked myself that control arm question. Is that what I would have done? So you know what, to be honest with you, I don't have a lot of patients on enalapril because it's a BID drug. I like to do once daily dosing of an ACE. Look at the sample size, 4,000 person randomized trial. The endpoint, all-cause mortality, something that matters. So this is the kind of study that is going to stay on my screen longer. All right, so the questions. What was the intervention? New drug plus valsartan. What was the control arm? Enalapril BID. Would you have done it? Probably not, but I guess some people must do it. I would have done some, once daily dosing with ACE inhibitor. What was the effect size? Pretty big. Clinical or surrogate endpoint? Clinical. What happened after the trial ended? I think they don't report it well, but they're looking at all-cause mortality and people are taking these drugs for years, indefinitely. So I think that's probably more of a question for cancer trials, so it doesn't really apply here. Any games with patient selection? All right, now I'm going to look for the answer to that question. I like this example so much because when you teach like medical students about clinical trials, I always ask them, if I'm doing a randomized trial and I have a new drug that's never been proven to work in human beings in the history of humanity, it's never approved, and I pair it with an old drug, and I randomly assign people, what do you want your control arm to be? And guess what they always say? What do they want the control arm? They want it to be valsartan 160 milligrams BID. They think the only thing you should vary is the new drug. And in fact, I think that's the perfect study. You take 10,000 people and you randomize them to this combination or valsartan, and you ask, does this new drug improve outcomes over the valsartan? And then somebody might say, well, who do you include in this study? And you could include people with heart failure who are ACE intolerant. So you could just do it in the ARB-eligible population if you think ACEs are better than ARBs, but they're probably almost indistinguishable. I think this is a nice, clean study. Then I look to see, is that what they did in this study? No, they used enalapril 10 milligrams BID. Then I start to look into it and say, what's with this dose? Is this dose really a fair dose? I mean, it's not often we compare different drugs. I find out this is the maximally FDA-approved dose based on package label. Then I find out this was the half maximal FDA-approved dose based on package label. So I say, okay, noted. Okay, but I read their explanation somewhere else where they say that, we had to use a half maximal dose because, a lot of people just don't take a higher dose. They get lightheaded when they take a higher dose, so you can't really push it much higher than this. We'll come back to that. So I look at the study. So they took 10,000 people, they randomized them to these new drugs versus enalapril. That must be what they did. Do I like this, that they're changing the backbone? Not really, but, fair enough. But then I look and I see their flow chart. I say, that doesn't match what I thought they did. They took 10,000 people, something happened, and then they had nothing happen, something happened. Okay, so I'm going to clean this up for you because it's kind of hard to read. Small print. Okay, what did they actually do? They took 10,000 people who are on ACEs or ARBs for heart failure, New York Heart 2 and 3. That makes sense. They made them all stop what they were doing and take enalapril, 10 milligrams BID for 14 days. Okay, it's a drug run-in period. I see that's what they're doing. 1,000 people discontinue the study in 14 days. Some people die, but some people can't tolerate that dose of enalapril, or they don't like it, or something happens to them. They have heart failure, hospitalization. But 1,000 people, 10% fall off the study. Okay, then what do? Then they make them take sacubitril valsartan for 28 days, twice as long. Now this is called a double drug run-in period of unequal periods of time. And another 1,000 people fall off the study. And if you think about it, it's kind of like a marathon. The first 1,000 people who quit the marathon are probably the least in shape, and the next 1,000 people are people who are fitter, but still dropping out. So now we got 20% attrition. These 1,000 people, I think, are different than these 1,000. And now we've done 1.5 month drug run-in period of 2 different drugs. Okay, now it's getting complicated. I said, this is what they're doing. All right, I got to think about this. This is not very intuitive. Then they randomize 8,000 people to sacubitril valsartan or enalapril. Then I ask myself, what are they actually doing here? They're saying, if you have heart failure, and if you tolerate an ACE for 14 days and our new drug for 28 days, is it better to stay on our new drug, because these people are just staying on what they're taking. They're randomized to this arm, and they just keep taking the same pill. Monday, they're randomized Tuesday, they take the same pill, same pill, same pill. This arm, they're randomized Tuesday, and they have to switch. The Wednesday, they have to take enalapril. They're switching their pill the day after randomization. So imagine you have 4 drugs in heart failure, hypothetically, A, B, C, and D. Imagine they're all the same, but every time you switch drugs, there's a risk of heart failure exacerbation because your body is not used to the new drug, there's an idiosyncratic reaction. If that were the case, that would only be a penalty paid by the control arm because the control arm has to switch, but the intervention arm gets to stay on what they're taking. Okay, so I thought that that's a little interesting. And 20% of the population is lost. I also think that now what you're doing to your study is you are gaming the population a little bit. You're creating an inclusion criteria to your randomization, which is you have to tolerate these 2 drugs. And it's kind of an inclusion criteria you cannot enunciate. You can't tell me what it is about someone a priori that leads them to discontinue the drugs. You can only learn that through this sort of gauntlet, this trial. And it leads to a population that cannot be defined by age or gender or race. I mean, you can't even say the inclusion criteria because one of them is to tolerate a very unique kind of drug trial, a drug test. Okay, then I had this kind of crazy question in my mind popped up. I said, I told you, I looked at that package label. It says usually the maximum dose of enalapril is 40 milligrams a day, 20 BID. This trial puts a limit on it. It says it's 10 BID is the max you can take on the trial. That's protocol specified limit. And then I said, by chance alone, some people who entered this study had to be taking enalapril, right? Just by chance alone. It's 8,000 people. Somebody got to have been taking it at the baseline. And somebody of those people taking enalapril has to be taking a dose higher than the maximum dose the trial allows. Because just by chance alone, it's got to be the case that somebody was taking 26 milligrams and they enroll on this study, and the study has capped them at 20 milligrams. And we also know that, the dose of ACE inhibitor or ARB is correlated with better outcomes. You're supposed to push the dose of these drugs. And I think a lot of cardiologists push the dose to the point the patient is almost a little bit lightheaded all the time. So I asked myself, what percent took a higher enalapril dose at baseline? Was there actually somebody who was taking 30 milligrams a day? They enter the study, and all the study does is restrict their dose to 20, actually pulls them down on ACE inhibitor. That such a person might be, unfairly harmed. How do I find the answer? So I look in the supplement. I'm just looking for this. And it says there is this sort of section of the supplement where they say there were 4 commonly used ACE inhibitors at the screening visit. And it tells you that 2,000 people out of the 10,000 people screened in this trial were on enalapril at baseline. So now suddenly I feel like, oh, more people are doing it than I thought. Roughly 20% of people were on enalapril. And they tell me what the mean dose of enalapril was, 16.4, which is less than 20. And they tell me the standard deviation was 8.3. So they've given me everything I need to know. Now I know exactly how many people were taking a dose higher than 20 milligrams. Here's how I know. I get one of those little calculators from online, and it calculates a normal distribution. And I put that mean, I put the standard deviation, and I put the cutoff of 20. And I ask, let's assume the enalapril is being dosed in a bell curve distribution. There's some people who can take a high dose, some people can't take a high dose. I think that's a reasonable assumption. And let's assume that's the mean and that's the standard deviation. What percent would be taking more than 20 at baseline? And the answer was 33%, 1 in 3. So what I think that this has shown me is that they have selected a population of people. They're not like the average heart failure patients in our clinics. Of course, trials are always picking people who are the creme de la creme. They're picking people better than average. And what they're doing is they're picking people who can really take doses of medication that's pretty strong. In fact, about a third of them were taking an ACE inhibitor dose, probably higher than the maximum dose they're permitted to take on study. The only thing that would happen to such a person, a third of the people on the control arm, is that the study will limit their ACE inhibitor dose at a dose below the FDA maximally approved level. I think that's what that shows. In fact, I know that's what it shows. That's what I think this is convincing me of. They could tell you the exact figures, but Novartis is, to be honest, they probably slipped up to let out this much information because it probably was a slip up. Like, why did we put that standard deviation and we just put the mean? Okay, so that was my next problem. So my first problem was double drug run-in period, unequal periods of time. That's odd. The control arm pays a penalty for switching, not the treatment arm. Second problem is enalapril dose is too low. There definitely may be people who are taking a higher dose at baseline. The third problem, this is a very odd trial. I mean, now it's looking like I don't see this too often. And so I asked Rosa Ahn, a medical student who works with me, let's look into this. I said, I want you to pull every single drug they've approved in the last decade, 2005 to 2016. It's 46 drugs. I said, I want you to pull every trial that led to drug approval in cardiology, 141 trials. I said, I want you to tell me, what were those trials look like? How many was a drug versus a sugar pill? It's 40%. How many was a new drug versus an old drug? 17%. And how many was drug A plus B versus drug C? And that is the paradigm study. Sacubitril, valsartan versus enalapril. How many trials were like that? And the answer was 2, and one of which is paradigm. Well, what was the other one? I said the other one was Bidil, which was isosorbide hydralazine versus enalapril, the initial study. And that was a study that found a signal for African-American patients only. And I said, well, what happened to that study? I said, well, the FDA didn't approve the drug, and they asked them to do a confirmatory trial before they would approve the drug. So that's how Bidil got approved. So I say paradigm is unique. There's only one other trial in history where 2 drugs were tested against a different third drug. And then I asked her about that run-in period. How many trials that are in cardiology even have run-in periods? She told me it was about 1/3. How many trials without run-in periods? It's about 1/3. And about 1/3, she said they didn't even report if there was run-in or not. I don't know for sure. And then I said, well, how many other trials had a double drug run-in period of unequal periods of time? And Rosa said 0. And so I said that this is an unprecedented trial. It's unprecedented because there's never been anything with a double drug run-in period, and there's only ever been one other comparison of A plus B versus C. So I also said that made me a little bit more suspicious. And then finally, it was unprecedented because it's only one study. There's no confirmatory trial. In these old days of drug approval, we would have 2 studies that tested whether or not a drug worked. And the PI of this study says you don't need 2 studies. We randomized so many people, it's like 4 studies in one. Our p-value's got 4 zeros in it. How many more zeros you want in your p-value? That's actually what he says. And then I said, that's a solemn summary of what he says. But then I say, why do you do 2 studies? You're not doing 2 studies because you want increased statistical purity. You're doing 2 studies to ask whether or not a drug works under a variety of circumstances, whether or not if you change the recipe a little bit, you still get a cake, or does the whole thing collapse? That's why you do 2 trials. So of course, sacubitril valsartan beats enalapril 10 BID at 160 milligrams of valsartan, which is a very high dose of valsartan. But does sacubitril valsartan 160 beat valsartan 160? If you looked at ACE-ineligible patients, does it beat captopril? Does it beat lisinopril, given to push to maximum dose? You want to vary something a little bit to see, is it something to this sacubitril, or is it just an artifact of this design? And so we wrote this paper in Circulation, Cardiovascular Outcomes, where we say, we need confirmatory trials for blockbuster cardiology drugs approved based on a single trial. And the other one I think about is Vascepa, the Amarin Pharmaceuticals fish oil. We've had fish oil study, negative, 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 positive, Amarin, and then 2 days ago, negative. The Merck study has failed for their EPA derivative. Okay, so one option. Amarin Pharmaceuticals and Vascepa is the only fish oil. They know how to cut that fish, like the Japanese chef and the Fuji puffer fish. They cut it in the only healthy way and give you the perfect fish oil, or there's something fishy about that trial. And what might be fishy about the trial is that what was the control arm taking? Well, they took mineral oil placebo. And how many mineral oil capsules did they swallow? A bunch. And how did you know they swallowed a bunch? Because 9% of them had diarrhea in the study. And what happened to their LDL? It went up 7 points. Why is their LDL going up when they're swallowing fistfuls of mineral oil? Oh, their statin might not be absorbed as well. So maybe the benefit in that trial is not that the fish oil is protective, but that you're giving somebody a mineral oil laxative treatment, and they're not getting their statin dose. I mean, nobody knows the answer. So that's the perfect study, confirmatory trial. There's no need to, why would you jump the gun? Ask them for one more. It doesn't fit, too. Every other fish oil study negative. How is this one fish oil positive? It makes no sense. But yet, they approved the drug. Actually, it went to drug approval committee, they approved it. So my conclusion of paradigm is, quote, not good. I don't know for sure what's going on here, but there's one trial, there are a bunch of things that trouble me. Conclusion, not good. Okay. Oh boy, time flies. I'm doing a slower job than at Providence, Providence St. Vincent's yesterday. All right, so I'll probably get through the next example All right, this is a cancer example. I told you a little bit before. This was like the first targeted drug for pancreas cancer. Pancreas cancer is a very tough cancer. It's almost, unfortunately, universally fatal when metastatic. And we haven't had any new drugs. All the drugs we use are drugs from like the 60s and 70s. There's no targeted drugs, no genomic drugs we use. And then finally, we have this olaparib for germline BRCA, New England Journal paper. This is going to be on obviously my desk a little longer. Before I tell you about this study, this is what I've learned from my talk yesterday. I'm going to teach you two things. One, what is progression-free survival? What the hell is that? And what is a response rate? Because that's all these oncologists keep talking about. What does that mean? Okay, so here's progression-free survival. What we do is we scan somebody and we find out that there's this tumor in the liver, and we measure that with calipers. And we all know that measuring a tumor in the liver with calipers on a CT scan, that's not like measuring my height. It's like measuring the width of a cloud between your fingertips. There's a little bit of, reader disagreement, and that's been shown in many studies. But imagine you have this much tumor at baseline, we start giving you the drug. What could happen? Unfortunately, a patient could pass away even before the first imaging scans. Okay, so if you pass away, that's considered one of the endpoints of progression-free survival. The first event could be death, unfortunately. What else could happen? You could get new lesions on the scan. The liver spot is the exact same liver spot, but now I got 5 new lung spots. That is not bode well. That is progression. That's a definition of progression. New lesions on scan that weren't there before baseline. What else could happen? Well, the tumor could get bigger, but it gets bigger. How do I know that it's progression? It's got to get 120% bigger. It's got to get 120% bigger. 119%, we call that stable disease. And these days, that's something people like to say. Well, it's stable disease, but it's 119% better, doctor. I know which way it's going. It's not going well. It's going to get 120%. 121% is progression. It's an arbitrary line, and I don't want to tell you. I'll tell you a long story someday about why they picked that arbitrary line. It has to do with a dinner party and 16 men. I mean, it's a very, very historical, arbitrary story. Okay, so that's progression. This is based on dinner party. This is the cutoff. This is the cutoff. Okay, what else could happen? Well, the tumor could shrink, and if it shrinks 30% or more, it's called a response. If it shrinks 29%, it's still stable disease, but 31% is a response. So if it shrinks to a response, then you only got to grow 20% from the smallest it ever was. You don't have to grow up to 120%. If you go down to 70%, you go up to 84%, that's progression. Okay, wow, this is progression-free survival, a composite primary endpoint of 4 different things. Any one of these events come first, you've hit the definition. Just like a lot of these diabetes trials, which is like, there are 3 events that lead to the progression in diabetes. 1, you could go blind. 2, you could be on dialysis. Or 3, your A1C could go up 0.5 point. Okay, well, yeah, they're a little bit unequal, but yeah, that's the primary endpoint of the diabetes study. Okay, this is bad, and this is not great. You can imagine that if I take people and I just find a way to select for slow-growing biology. So let's say I run a clinical trial. It takes 4 weeks of studies before you can enroll on my study. A lot of people, unfortunately, will pass away in those 4 weeks, and I've selected for people whose tumors grow slowly. Then I put them on a study, and then I say, oh, my progression-free survival was 8 months. It took so long. We're used to 3 months. Well, I've excluded everybody whose tumors grow quickly, and I only have sort of a group enriched for slow growth. Okay, back to this study. Okay, so they took people, so this is the results. So I look at what's the primary endpoint that was improved? Well, it's progression-free survival. Of course, it always is in cancer medicine. Here's the study. Instead of 3 months of progression-free survival, you got 7 months of progression-free survival with olaparib. Okay, well, that's something. I can see that difference. There's an old saying in oncology, if you can fit a laser pointer between the curves, you can give a plenary session at the national meeting. And so I can do that. I can do that. But overall survival, what I really care about, well, that looks like a wash to me. But don't worry, that's never stopped us before in cancer medicine. We're not going to, let's just delete that, get rid of that. Okay, so what was the intervention? Well, we gave people this fancy new pill. Is the control arm what you would have done? Well, we gave people sugar pill. That's not what I would have done. We took people who had given 4 cycles of platinum therapy, 4 months of platinum therapy, and then if they had their disease responding but hadn't progressed, we would randomize them to the new drug or sugar pill. That's not what I would have done. I would have given 6 months of therapy and then continued one of the drugs, and that's what I think most pancreas oncologists would have done. So they might be depriving the control arm of some of the drugs we've already proven have a survival benefit in their study design. Okay, What was the effect size? I think it was medium. Clinical or surrogate endpoint, surrogate, not the endpoint that matters. What happened after the trial ended? We'll come back to that. Any games with patient selection? I think not so much there. They just took people with germline BRCA. I mean, you need to know germline mutation status. We don't do that, but they can do that if they want. Then I typed in the trial name and I hit Google Images search. And when you type in a cancer drug and hit Google Images, you will get the best slides ever because the drug company makes better slides than anyone else. So I did that, and here's what I found. We took people with this mutation. They had no evidence of progression after 16 weeks of those drugs. We randomized them 3-2 to olaparib placebo. I could give you a whole lecture on why this is a little odd and I don't like it. But okay, 3-2 randomization, the new drug placebo, PFS, that's what they did. One more thing I need to tell you. I showed you this figure, that some people you give a drug and they have a response. We've done many, many clinical trials in oncology, and we know response rates for drugs that are approved is anything from 5% to I guess, imatinib, Gleevec is 98%. Those are range, or maybe 100%. So that's the range of response rate. Average, maybe about 20%. But we've done placebo-controlled clinical trials in oncology. So we've given sugar pill to a lot of cancer patients, and some of them actually had response. Why does somebody who gets a sugar pill have a response? Because it's like measuring the width of a cloud, and so maybe there's some measurement error. Do I think sugar pill is shrinking tumors? Not really. But do I think there's a little bit of measurement error? Yes. So I happen to know a fact, which is many years ago, some smart guy in Toronto, he went through every placebo-controlled trial, and he added up how many people had response just getting sugar pill. And the answer was 2.1%, 2%. And the most he ever saw was like 5%, and the least he ever saw was 0%. And I guess that's believable to me, that 2% of the time, the radiologist, looks at it differently and they think it's a 30% difference. Or you scan someone a few minutes apart and actually based on the slices, it actually looks a little different. So there's gonna be some error rate. Okay, I know that. And then I look in Polo trial and I say, how many people had response? And I find if you take olaparib, 19% of people had that response, 30% shrinkage. But if you took placebo, 10% of people had a response. If you took a sugar pill, 1 out of every 10 people had the tumor shrink by 30% or more. And then I think back, that Toronto paper, you'd never seen that. The average is 2. The highest it ever was like 5 in one prior study. Why, in this study, with this design, did 10% of people have tumor shrink in the control arm? Does pancreas cancer shrink when you give a sugar pill? No. Why in 10%? Yeah, I thought about different radiologists, but the other study, there's always different radiologists in all the other studies, every placebo-controlled trial, and you never got a figure this high. Something about this study that's different. I told you I would have given more chemotherapy. Their tumors are shrinking because they got chemotherapy. They're still shrinking from the chemotherapy they got weeks and weeks ago. They're still shrinking from that chemotherapy. Imagine if you had just given them a little bit more chemotherapy. These aren't average patients with pancreas cancer. They're like all trials. They're younger, they're healthier, they have better functional status, better socioeconomics, and they're getting chemotherapy, and after 4 months of it, which I told you I like to give a little bit more, after 4 months of it, some of them have tumor shrinkage. And then these investigators make them stop, which I think nobody would do. They make them stop and take sugar pill, and still, a little bit later, 10% of them have even more tumor shrinkage from chemo they got weeks and weeks ago. That just tells you that they're picking people whose tumors are like exquisitely sensitive for chemotherapy, and they're depriving them of that chemotherapy, which has already proven survival benefit, and they're still having tumor shrinkage weeks later because the pancreas cancer is slowly dying and the tumor is getting reabsorbed, et cetera, et cetera. So I think that the moment I saw that, I was like, oh, that's why. So they're really taking people and they're kind of giving them something that's probably actually harmful. And if you had given them more chemotherapy, the overall survival curves might have separated in the other direction. Placebo arm gets better. Okay, so here's how I would try to articulate it. You halt a therapy that is normally not halted, and you randomize people to a new costly toxic pill or placebo. You measure an endpoint that is not a measure of what matters and historically has never been accepted in this cancer type ever. You don't improve survival, you don't improve quality of life. You just improve a radiographic endpoint that's prone to error. So what does the US FDA do? On the question of whether olaparib has a favorable risk-benefit profile, they vote in favor, 7-5. And that's where we are right now. Not yet approved, but it's coming. And the answer is, quote, heck yeah. Heck yeah. A drug that doesn't make you live longer, doesn't make you feel better, in a trial where the control arm probably was harmed because you took away something that was actually effective. Heck yeah. Well, that's the state of the beat. Okay, so those are the major objectives of this lecture. What are the best techniques to keep up with the literature? I think the answer is it has to be built into your routine. You just have to have a way of looking at 1 or 2 articles a week, and the best way I know to structure it is to structure it around when the articles come out, so that way you can be a voyeur and take part in the conversation. You can just watch what people are saying about it online, and that'll help like both make you a better reader, because if you kind of skim an article and then you see that, oh, you know, all these doctors on Twitter who are pointing out things that, you know, I never thought about, and you do that a couple times, you'll become a better reader of the article. And it doesn't take that long. Like, I literally do most of it in elevators, or waiting for an elevator, and unfortunately, while waiting at a red light, which I shouldn't do, but that's another peak usage time, red light. Okay, so that's how I keep up with the literature. What are some examples of studies that are misinterpreted? I think the Paradigm and the Polo trial have something in common, which is that by all accounts, they look good. Randomized trial, new drug control arm, you know, they measure the endpoints fairly, good sample sizes kind of studies, but the problems are subtle problems. How did they put the people in the study? What exactly was the drug they tested against? How do they measure the endpoint on the back end? And I think those are the common ways we see studies kind of gaming it, and the reasons why I think we should be critical of studies. So I think those skills will allow you to be a better reader of the medical information. We got a couple minutes. I wonder if I can get through my next thing, but I could also take questions. Should we end promptly?
I would like to see your last thing, actually.
All right. Okay, you want to see the last thing? Okay, if anyone needs to leave, you can feel free to step out. I'm never offended. People leave my talks all the time. Okay, so I think for many of us who look at the New York Times Well column, it feels like this is how they write the stories. Nick spins the wheel. He says, today's story is coffee can cause spin the wheel, depression in spin the wheel twins. Boom, I got a story. Let's run with it. And his wheel, he's probably updated. Now it's red wine, dark chocolate, green tea, alcohol use, coffee, berries. I like to say that, if you do a news story if you do a research berries, you got a shot at the New York Times. You do something on a pitted fruit, like a peach or a plum, you get the hell out of here. You throw your career away, you want to study pitted fruit. Just throw it away. It's only berries that get you there. Okay, so a few years ago, I really read this. Vitamin E increases death. Oh, no. But then 2 weeks later, vitamin E mortality study challenged. Oh, I'm back at Costco buying vitamin E. Okay, it's always like that. It's always flip-flopping. Well, why does it flip-flop? Well, a couple years ago, somebody kind of explained why it flip-flops. You gotta think about how we do these studies. We get this data set, and we know what people ate or drank, many, many years ago in the past, and we know if they lived or died. I know how many tomatoes somebody ate and how often they ate broccoli and whether they took vitamin E and whether or not they drank green tea, and this data set is called NHANES, and there's 400 variables in this data set I can ask. I know whether or not they lived or died. I know if they got breast cancer. I know if they got pancreas cancer or myeloma. So I know if they do 5 metabolic equivalents of exercise back then, they're less likely to get myeloma now. I can ask all these questions. How do I ask these questions? I set up a regression analysis. I say, what do I care about? I care about death. And what do I want to know if it led to death? I want to know if vitamin E led to death. But I also want to adjust for other factors like age or sex or race. And I'm an investigator in Portland, and I can download the data set, and I have stats on my computer, and I can run this in 5 minutes if you give me the data set. Literally 5 minutes, I get you the answer. And my friend lives in Toronto, and she runs it, she adds income, because in Canada, they care about socioeconomic determinants of health. We don't care about it, but they care about it, so she remembered to put income in. Then my friend in North Carolina, she's a very good researcher. She steps out of her office every day and sees so many people smoking. So she remembers to add in smoking. And my friend at Harvard, he knows how to publish well, and so he adds in BMI and hypertension, diabetes, cholesterol, alcohol consumption, education, family history. He is definitely going to publish well. He puts it all in. So a few years ago, researchers realized a couple things are true when it comes to these unique questions that are always in the newspaper. One, many investigators have access to the data. And many, many people are probing the data all the time. And they are probing it more often for dark chocolate and tea than they are for cauliflower and peaches. Just because More people are interested in dark chocolate and tea, for whatever reason. Each researcher who probes this data set adjusts for some variables, covariates, that make sense to them. Age and sex made sense to me, but I didn't think about smoking. I didn't think about income, but that makes sense to you. And the moment you write your paper, we can all justify why we chose what we chose. I mean, I don't think people quibble with the adjustments too often. And so they said, what if you simulate not just me or my friend or my two friends, you simulated everybody in the world who's looking at this question simultaneously, asking this question, and that's what they did. They took 13 variables that are commonly used, and they said, let's adjust for one of these, two of these, and all possible combinations of up to all 13. Okay, so they're adjusting for every combination, and they create these scatter plot clouds, and this is a heat map. And this is just one. This is like, I think, I don't know, I think it's vitamin D and mortality. And what is it saying? On one axis, every dot on this plot is a study that could have appeared in the New York Times. Every dot. And the hotter it is the more studies that reach that conclusion. On one axis, they plot the hazard ratio. A hazard ratio of 1 means no association. 0.5 is a big association. 0.2 is a huge association. On the other axis, they plot the significance. Actually, the negative log 10 p-value. But you don't need to know that. Okay, so they're plotting like what they're finding. And each of these dots is a study, a study, a study, a study, a study. What do you think the most common hazard ratio they're getting out for every nutrient and mortality? The most common hazard ratio is the same for like every nutrient and mortality, and it's 1. Then it doesn't have anything to do with how long you live, vitamin E and coffee and green tea, but they're also getting a few dots that are provocatively beneficial and provocatively harmful. And when you think about the incentives in the system, we don't see the middle. If my postdoc comes to me and says, I found 1.0, I say, why are you even talking to me? In fact, she might not even come talk to me because she'd say, that's such a trivial thing. Why would I tell this guy that? And then if she comes talk to me, I'll say, well, don't write that up. It's not even worth your time to write it up. It'll be published in a terrible journal. No one will want to read that. And so it dies right then. Let's say it comes back at 0.89, but it's non-significant. Then it comes to me, we write it up, we submit it to the journal, but they reject it because it's not significant, it's not interesting. Now it's a 0.7 and it's significant. Then they come to me, I say, oh, let's write that up, let's submit it. Okay, let's get it in. It gets published in the journal. New York Times says, oh my God, it's significant, let's cover it. All of the incentives along the way are to cover these dots, and nobody wants to talk about all of us who get null results that you just don't take it anywhere. And that's why when you look at, these were randomly selected ingredients from a cookbook, you can find randomly selected, 80% of them are linked to cancer, either favorably or negatively. And I think that it shifts with like social attitudes. Like coffee was once probably more negative, but we've kind of just changed how we feel about coffee, and now more of the studies are positive. Beef, we don't feel so good about red meat still to this day. It's still on the negative side. But recently, I think that's kind of shifting. People come bringing it back in. I see people putting butter in coffee, so now we got a few more people on this side. So I think it'll keep pulling over. I guess what I would say for these common things, you will never get truth out of these studies. It's literally just an opinion poll. It's an opinion poll of what people think is plausible. What's being reported in the study is what people think is plausible and worth talking about, and what is not being reported is the entire middle. And it's different than clinical trials, because when you run a clinical trial, you can only run it so many times. You can run it once, you can run it twice, maybe 5 times, 10 times. But you can't run it as many times as you can retrospectively look at nutritional foods and outcomes. You can run this 100,000 times. Maybe on any given day, 50 people are looking at coffee and outcomes. And every minute of the day, 50 people are probably probing that relationship. An order of magnitude higher than cruciferous vegetables, maybe. So that's why we're going to get more coffee stories, and they're going to be more sensational. All right, so thank you so much for coming. It was an honor to give this lecture. I'm happy to stay for questions.
I think in the interest of time, if you have questions, come up front. Otherwise, thank you very much.
Thanks.
That's just fantastic.
Oh, good. I'm glad that people will like it.